Good morning. Happy New Year to you all. A couple of changes. One, those of you who prefer to sit in the back, that's great, but you now have a job. We are finding that for some of our grand rounds, when we get the room full, that folks are coming in and sitting on the stairs. Our fire marshal has said that is no longer acceptable behavior. So if you're sitting on the aisle and someone is sitting in the aisle next to you, you're to go reach over and tap them and say, we need to get you in a chair. Because our grand rounds usually has more than enough room for everyone to sit in. I gave up years ago trying to get people to move to the front of the room. We teach it right at the beginning of school or church or synagogue or even mosque that the back of the room is always better. I'm not sure that's true, but I would urge you to help us with the other. We're beginning the year with one of our ethics grand rounds, and as I hope you've been finding over time, these are always wonderfully thoughtful and thought-provoking activities. Our intent is not to give you the answer, but to give you food for thought. With that, I'm going to get Ben to come and do the intro. Oh, Doug is going to do the intro.
Thanks, Tom. So good morning, everybody. I have the pleasure of moderating today's Ethics Grand Rounds and introducing our three speakers. Before I do that, I wanted to take a few minutes to remind everyone about the format of this Ethics Grand Rounds. It's meant to be a case-based consideration of an ethical issue in pediatrics, and the case is inspired by actual events but is generally modified and is really intended as a starting place to consider the issues raised. The case will be presented by children's clinicians for today's Grand Rounds. The case presenters are Dr. Carrie Hieke and Dr. Richard Hopper, both of whom I'll introduce shortly. There will be an opportunity to ask questions of clarification after the case is presented. The case then will be followed by a commentary for about 20 minutes by our invited guest, Dr. Jeffrey Brosco. After the commentary, we want to stimulate discussion and invite you to make way to the aisles where there are two microphones situated if you would like to ask a question or have comments. Lastly, before introductions, I wanted to mention that Ethics Grand Rounds is sponsored by the Truman Katz Center for Pediatric Bioethics and is supported by a fund established by Jeff Sconyers and Deborah Godfrey. Ethics Grand Rounds occurs quarterly. The date of the next Ethics Grand Rounds is scheduled for May 14th and will feature guest presenter Dr. Chris Feutner from the Children's Hospital of Philadelphia, speaking about physician obligations for treatment of hypoplastic left heart syndrome. So now to introduce our case presenters. Both Dr. Hieke and Dr. Hopper are part of the craniofacial team here at Seattle Children's. And Dr. Hopper serves as the team's clinical surgical director. Dr. Hopper is chief of the Division of Plastic Surgery and an associate professor in the division and the Department of Surgery. Dr. Hopper's research interests include craniosynostosis, cleft lip and palate repair, and craniofacial syndrome. Dr. Hieke is an acting assistant professor of pediatrics, also a member of the craniofacial team. Dr. Heike's research focuses on the genetic epidemiology of craniofacial conditions, and she has special interest in working with families and children with 22q11 deletion syndrome. Our commentator on the issues raised by today's case is Dr. Jeffrey Brosco. Dr. Brosco is an associate professor of pediatrics at the University of Miami Miller School of Medicine. He is director of clinical services for the Mailman Center for Child Development at the University of Miami and is chair of the Pediatric Bioethics Committee at Holtz Children's Hospital and Jackson Health Systems in Miami. Dr. Brosco's current research focuses on social history and public policy trends in healthcare for persons with developmental disabilities. We are delighted to have Dr. Brosco here today. So without further ado, let's have Dr. Hieke start with the case presentation.
So this is my disclosure slide, and is this volume okay? So one thing that I've come to very much value about working with the craniofacial team is that there truly is no I in team. So I've altered our disclosure slide. So we had our initial visit with our patient at her craniofacial outpatient clinic evaluation. And at the time, she was 3 months of age. and the chief complaint was a unilateral cleft of the lip. During her visit, she was scheduled to have individual consultations with members from pediatrics, plastics and reconstructive surgery, nursing, and social work. During our interview, we learned that she was born to a 36-year-old, gravidivore para-1 mom and a healthy, unrelated father. Mom reports that the pregnancy was generally unremarkable and that she experienced some mild hypertension towards the end of pregnancy but did not require medical management. She had a prenatal ultrasound at 18 weeks, and the study revealed that the fetus had a ventricular septal defect, and there was a suggestion that she may have a cleft of the lip. The quad screen was indeterminate, and the parents declined further evaluation with either amniocentesis or more detailed imaging. So she was born at 39 and 3/7 weeks gestation. She was delivered via C-section for breech presentation. Her ACLARs were 4 and 5, and at the time of birth, she was noted to have multiple anomalies. Her facial features were notable for small palpebral fissures, hypertelorism, mild micrognathia, small and posteriorly rotated ears, and a right cleft of the lip and alveolus. She also was noted to have clenched fists, and her feet were notable for rocker bottom appearance and distinctive toes. She was transferred to the neonatal intensive care unit, where she was cared for the first 2.5 months of her life. During that time, she was treated with a nasogastric tube for nutrition. She had her ventricular septal defect confirmed on newborn echo. She was also noted to have microcephaly, and MRI revealed cerebellar hypoplasia. So at this time, a genetics consultation was obtained, and the karyotype revealed 3 copies of chromosome 18. So what do we know about trisomy 18? Well, if you look at Smith's, which is an excellent place to start, it lists a number of anomalies that are associated with this condition, and they're kind of grouped into these organ systems. But what if we wanted to know more about specific anomalies and the prevalence rates of these anomalies in this condition? So there are a number of case series and small case reports, but only really a handful of large population-based studies on this condition. And I'll give an example of one nice study that was done by Palate et al. In 2006, and I will give some caveats which the authors readily acknowledge. That one of the challenges of doing these kind of large-scale population-based studies is that they need to rely on ICD-9 codes for documentation of these associated anomalies. So those anomalies that were not coded are not represented, and those for which codes are not available are also not represented. But it provides some great information, and what we learned from this study is that 45% of children with trisomy 18 had some type of cardiovascular anomaly, and they're listed here. And the most common of these was the ventricular septal defect. And 8% of this population had one of these 3 gastrointestinal malformations. 3% had one of these limb anomalies. For the craniofacial conditions that they assessed, 8% of this population had one of these anomalies, and cleft lip was the most common. And you can see that 8% of this population had CNS anomalies, 3 and 4% respectively had genitourinary and abdominal wall defects. So this is a condition that's typically diagnosed initially suspected based on clinical features, and then really requires cytogenetic confirmation. And it's possible to diagnose this condition prenatally. You can get some information from the early screens, and then definitive confirmation via CVS or amniocentesis. So how common is this condition? And that's something that's really challenging to try to assess during pregnancies, and some of the best studies, which really kind of look at pregnancies that made it through the second trimester, estimate that the prevalence is approximately 4 in 10,000 pregnancies. And we also know that there's a high number of prenatal losses, both due to spontaneous and elective terminations. So the birth prevalence is close to 1.3 in 10,000 live births. Most studies are pretty consistent looking at the prognosis of this condition. Half of children die before their initial newborn discharge, and the median survival is between 6 and 14 days of life in most studies, and about 5 to 10% of infants will survive to 1 year. The primary causes of death for children with trisomy 18 include issues related to their congenital heart disease, prematurity, respiratory distress syndrome, multi-organ failure, and sepsis. So there was another nice large-scale population-based epidemiologic study by Rasmussen et al. That specifically looked to assess some of the characteristics of patients with trisomy 18 to determine whether or not there were certain characteristics that were related to increased survival time. And they looked at race and ethnic background. They looked at gender, presence or absence of a cardiac defect, and they also looked at trends over time. And you can see there the breakdown that they used for that. And they had 114 patients in this study, and they were very clear about the fact that these results are limited by the small sample size. But they did say that you can see that there were some tendencies to be some differentiation in terms of lifespan based on ethnicity and race. One thing that they were clear about is that there does seem to be a difference between males and females, and that females on average tend to live 2 weeks longer than males, and that's something that's been supported by other studies. But interestingly, there did not seem to be a difference in survival rates among those who had a heart defect versus those that did not, nor did there seem to be a difference in trends over time. So how do these statistics compare to those around the world? And again, there was a nice study by Lin et al. In 2006, and this was actually based in Taiwan. But one nice graph that they showed was really a comparison of different centers around the country and their survival statistics. And their conclusion was that these are similar statistics around the world. So back to our patient. So at this visit, her parents were very concerned about her limited lifespan, and they requested that the lip repair be performed within the next month so that she would be recovered in time for their annual holiday photograph. During our interdisciplinary meeting to discuss this request, the third-year medical student asks, is it appropriate to do cosmetic surgery on a child with profound developmental disabilities who's not likely to live a long time?
I guess that's where I step in. Tough question. I just wanted to give an overview of cleft lip, and this is very brief, only 3 or 4 slides, just to be able to put the surgical aspect into context. I think the first thing is that most of plastic surgery is a blend between form and function. We obviously want to achieve the functional benefits, but the form is important both to the team as well as to the family and the patient. In a cleft lip repair, not all cleft lips are the same, so you'll have a transition or a spectrum, as you'll see on the bottom, from left to right to a relatively mild external deformity to something that's more severely affected, such as the complete bilateral cleft lip that you'll see on the far right. The risk-benefit ratio does vary from patient to patient, but less than you would think in terms of the functional benefit you're going to get from the surgery on the left will be less than the right, but the risk of the surgery overall a little bit less on the left than they would be on the surgery on the right, so the risk-benefit ratio tends to be pretty constant from left to right. The improvement of form, I'll show you in the next slide, is pretty obvious. You're normalizing the anatomy and creating a facial structure that would be acceptable in our current society. The functional benefits for the cleft lip repair, so not the cleft palate repair per se, is to restore the oral sphincter, so oral competence is achieved, so it cuts down on drooling and it helps with swallowing for the first initiation of swallow. From a speech point of view, for patients that will develop speech, articulation is very important, as you know, when you use your lips to speak. And also the separation of the oral and the nasal cavities, which, as you can see, especially on those the middle slide and the far right slide, the oral and the nasal cavities are in continuity. And so the airflow comes up into the nasal cavity gets scabbed, bleeds, ulcerates. And so separating it and reestablishing normal nasal airflow is obviously a functional benefit. The discussion that will follow will bring into question, is there any functional benefit from doing a cleft lip repair on a patient with a very severe developmental delay where speech and swallow and breathing may be altered to the point that the functional benefits are less evident. I'm not going to give a detailed description of the surgery, but the actual skin incisions are limited to minimize the scarring. And it's a series of plastic surgery techniques of robbing from certain parts of the lip to give to other parts of the lip and adjusting the tissues through rotations and transpositions and alterations. But the actual cutaneous pain in terms of the length of the incision and the amount of nerves that are cut to get down to the surgery, as you can see, are limited by those little lines that you see right there. The case that Carrie picked out was a unilateral complete cleft lip and palate, so it would be very similar to this child that you see on the upper left. And the surgery is limited through those incisions, but it actually goes underneath the skin, around the cheek, up around the inside of the nose, over the nose, underneath the skin, and then back down the other side, and then to the level of the bone at this level right here. So it's a little bit more invasive than what you see from these pictures. But through a 2-hour operation, you are able to normalize the nose and the lip. This is a patient with a very early scar formation, but that would be sort of a standard result that the parents could expect from this type of surgery with this case. Now, just my personal experience, I've had 3 patients with trisomy 13. My personal experience was that the guardian was a very competent, aggressive advocate for the patient in all 3 cases, and all 3 pushed very heavily for the lip repair. 2 decided to go forward with the lip repair. The one most recently has decided, after pushing for a number of months, saying, no, actually, I've changed my mind. I'm going to hold off on the surgery. The 2 that had the surgery, it was an interesting sort of catharsis I think they go through after the surgery. They're happy with the appearance of their child, but there's almost like a decompression or deflation of their emotions. They tend to be at a flatter level than a parent who had a child had a cleft lip repair without the severe developmental delays. There is a difference, and maybe we can talk about the difference in terms of the guardian's or the family's response to this surgery. So finishing off, what is the risk-benefit ratio? Because I think this is something that we do have to build into this discussion. What's the chance of this patient dying on the operating room table, or what's the chance of them getting a severe complication from this 2-hour procedure? Charlotte Lewis, Jackie Starr, and I and Michelle Garrison did a study trying to look at the feasibility of outpatient cleft lip repair. And so this is a spin-off table that looked at what are the national complication rates associated with one-stage primary cleft lip repair. So it's that scenario of an infant undergoing a cleft lip repair. And it was the FIS database, so it was, I think, 23 standalone pediatric centers. Just over 2,500 cleft lip repairs, primary cleft lip repairs. So it was a reasonable cohort. And the things in red are things I just wanted to touch on. Around 11% of those patients that are undergoing this operation have comorbid diagnosis. And so this is not things like eczema. This is like severe asthma, congenital heart disease, developmental delay, recognized craniofacial syndromes. And the range from hospital to hospital going from 2% up to, and probably closer, we're sort of around the 30% range, I would say, but some hospitals had up to 50%. The chance of a serious medical complication occurring after this surgery, and so this would be serious. This would be cardiopulmonary resuscitation, need to intubate for over a 96-hour period, that sort of level of complication, was 1%, and it ranged from hospitals from 0 to 4%. The charges, because I think we also have to build cost-effective delivery into this discussion, the adjusted charges for the operations is mean of $8,000 with a range of $3,000 to $12,000. Unfortunately, that's not my fee. That's the hospital charges and everything else. So it's certainly a cost, but relative to other operations, less. And then finally, out of the 281 patients that had cleft lip repairs and also had a severe comorbid diagnosis, so that would, for example, that trisomy patient would fall into that category. 17 of those had a serious medical complication. So 17 of those had either a cardiopulmonary arrest or a severe airway complication or need to be in the ICU for prolonged periods of time. So that brings the complication rate up to 16%. So if I was counseling this family, for example, I would say you would have at least a sort of a 1 in 5 chance of something happening that we would have to institute a higher level of medical care, which would increase length of stay and increase the risk of severe morbidity or mortality. One thing just to finish off is through our review of 200 cases here and 200 cases consecutive at sick kids in Toronto, there were no mortalities, but the complication rate of severe complications was around 1.1%. And also in this series, we were not able to pick up a mortality that occurred while in hospital. We don't have the data to be able to figure out if something happened on discharge, but during the hospital stay, there was no mortalities. I think that transitions us to the question slide.
Thanks, Dr. Hopper and Dr. Hieke. Before we move on to these questions that this case raises and Dr. Brosco will address, do we have any questions for Dr. Hieke or clarification about the case or what Dr. Brosco or Dr. Hopper mentioned? Okay, Dr. Brosco.
Doug, could you switch over the slides for me? First of all, thank you all for having me here. I have many friends and colleagues here in Seattle, and I feel a bit like I'm coming home. In fact, I think this is my 12th trip to Seattle in the last couple of years. Thanks in part to Ben Wilfine. I really want to thank him and the Truman Katz bioethics group for having me here. I'm really honored. So, actually, did we skip ahead already? All right, yeah, we're in the middle of it, all right. So, these are the questions that came up, but don't bother reading them yet because there's no way we can get to maybe any of them. We have about 40 minutes, and it's impossible. There's too many great questions in this case. But there's really one big question, right? And that's, thank God there are third-year medical students who are willing to speak up and say, wait a minute, does this really make sense? Is it appropriate to do this? And I found that when I do these talks, it's fun to have a lot more interaction, so that's my plan. I have a few slides and give you some background, but I really want to make this interaction. Dr. Pendergast, this is how I get people to sit in front. Ready for this? People who are in back are my volunteers and have to spontaneously spout off on ethical issues. So if you don't want to be a volunteer, move to the front and sit. If you stay in back, I assume that you are ready to volunteer. Sometimes it works. Okay, so here's the big question, and you all have to vote now. Don't worry, you're going to get a chance to vote again towards the end, and I will tell you what I think about this. But I think it's important to, even if this is based, your initial vote is based sort of on instinct and gut feeling, that's all right. I mean, I want you to have some skin in the game, as they say. All right, and I'm watching to see, because if you don't vote, okay, I'll remember which of you don't vote, and I'll make you vote in front of everyone. So you have to vote. So how many of you think, yes, this is appropriate to go ahead and do surgery on this child from what little bit you know now? All right, raise your hands. Okay, I'm scanning who's not raising their hands. Okay. Now, how many of you, presumably all the rest of you, think you should not? I think, all right, yes, there you go. For a second, you didn't vote. I thought I was going to have to make you do it in front of everyone. Okay, so it was about 2/3 yes and about 1/3 no. And it'll be interesting to see if that changes after I present a little bit more information. Okay, so the disclosure that you've seen before, this is the standard slide. Notice I added a bullet, and it says that I'm a pediatrician, a developmental behavioral pediatrician. And actually, I was part of a Cleft, Lip, and Palate team for a couple years, and sometimes historian. But I'm not a philosopher, and I don't pretend to have any great understanding of moral theory, so there's not a whole lot of that today. Well, one thing that I would like to do is get a little bit into some of the background of this. And when I take that question from the third-year medical student, I sort of break it up into 3 parts. So is it appropriate to do cosmetic surgery on a child in general? And we'll talk about this a little bit today, but it's hard to get into it too much because there's a huge amount there. Secondly, is it appropriate to do cosmetic surgery on someone with a profound developmental disability? And then thirdly, on someone who's not going to live for a very long time, or it doesn't seem to be. Now, I should say right from the very beginning that I use the word cosmetic surgery only because the third-year medical student did. And I'm not at all convinced that a cleft lip repair is cosmetic surgery. I think almost all of us would agree it's not, but that is an issue we can come back to. So I sort of divided up into these 3 issues when trying to figure out the bigger question. And this actually ends up being the outline for a little bit of presentation I want to do before I start. So is it okay to do some sort of surgery on a child? Well, I think we need to understand a little bit about the historical epidemiology of child health and a little bit about what we're going to call the technological imperative in modern medicine, just to kind of give us some background to how we come to these decisions in a way that probably most of us don't think about very often. Then secondly, is it appropriate to do these sorts of interventions in someone with a profound developmental disability? And I think absent an understanding of the history of persons with disabilities, you can't begin to approach this question. So I'm actually going to spend maybe 5 or 10 minutes on this particular issue. And then this last part is about someone who's not likely to live for a very long time. And here we'll get into some more interaction. We'll do some basic clinical ethics, I think, to try and figure that out. So just quickly about the epidemiology of child health. There are 2 key points here. One is, and I think you all know this, there's been spectacular improvement in child health in the last century. It's just absolutely extraordinary, and I'll show you one graph in a second. But secondly, this incredible improvement in child health contributes to the idea that we actually had something to do with it, those of us in the healthcare professions. So if you look, for example, this is a graph of infant mortality rate. So this is deaths before the age of 1 year, starting in 1915 and up through 1995. And what you can see is It's gone from about 1 in 10 children dying before a year of age down to what? Maybe 8 in 1,000 or something like that, less than 1 in 100. And what this graph doesn't show you is if you look at early childhood mortality, that is death by age 5, and you look at around the turn of the century, it was as high as 300. Infectious diseases, pneumonia, tuberculosis, gastroenteritis, took the lives out of 1 out of every 3 or 4 children. Just stop and think about that for a second, only 100 years ago. And of course, as many as you know, there are places in the world where this is still true, where child mortality is huge. And it's hard for us to remember because there's sort of a break point around 1950, 1960, where it's pretty unlikely that a child's going to die from an infectious disease. And really, all of child health, all of pediatrics kind of pivots around that time, where we almost stop worrying all the time about a child dying from an infectious disease and start thinking about other issues. The second thing that's not on this slide is some work that was done by Thomas McEwen and here in the United States by the McKinleys. And we sort of tried to replicate it a little bit looking at historical epidemiology of mental retardation, and that's a talk I'm going to do later today. But does anyone know when antibiotics became commonly used in the United States or Western Europe? Anyone know around when? 1940s, 1950s. So World War II, some penicillin was available. Penicillin was the wonder drug. It worked on all the organisms. There was no resistance. It was great. Anyone know when immunizations, now immunizations have been used for at least a century, but when they actually were effective and made a difference? Mostly in the 1960s. Okay, so here's what McEwen and his colleagues pointed out. He said, if we have antibiotics and immunizations here in the 1950s and 1960s, how do those medical interventions account for the mortality transition? This is not to say, by the way, that antibiotics and immunizations don't work, right? I'm not saying that at all. But what I am saying is that if we want to understand why children don't die from infectious disease nearly as often as they did, it has very little to do with what doctors and nurses do at the bedside. It has a lot more to do with nutrition, public health, a whole lot of other things, which, of course, we're all part of. But it's hard for us to argue that it's been doctors and nurses and people at the bedside fixing kids who are sick that's changed child health in the last century. And this sort of leads to this technological imperative in medicine idea that's worth understanding. It's this idea that it's scientific medicine that's the key to child health. So whether we're talking about vaccines, antibiotics, surgery. And by the way, surgery is probably one of the things that did change pretty dramatically at the turn of the century. And Charles Rosenberg has called this inward vision, outward glance, this idea that we in healthcare professions are spectacular when it comes to someone at the bedside and figuring out how to take care of a tiny preemie, how to do surgery with the fewest number of complications. But as a general rule, we're not so good at thinking in a broad public health sense, sort of that outward glance. We don't notice as much. So there is this technological imperative in modern medicine. Our payment schemes work this way, our DRGs, everything does. So it's important to keep that broad history in mind. Okay, now I want to make a transition and talk just very briefly about the history of persons with developmental disabilities. And this first slide is what I'm calling the negative history. Right? This is all the bad stuff. And probably a lot of you kind of know it in some informal way, even if you've never studied it. So on one hand, there are centuries of discrimination, lack of civil rights, obvious prejudice, stigma. And this has been true in just about every culture across time. And many of you know that this sort of reached its epitome, I guess, in the Nazi times when gas chambers and other efficient ways of killing were sort of perfected on persons with disabilities. The other part of this that sort of keeps going in medicine in some ways is this idea that someone might not be worthy of treatment. If someone has a developmental disability, well then why are we bothering? That kind of, we so prize normalcy, cognitive ability, physical ability, that if someone doesn't have those abilities, then they're somehow less of a person. There's almost a reverse of that as well in medicine, which is what's commonly called the medical model, and that is that it's generally our role in medicine to try to fix someone. Right? Someone comes to us, there's something wrong, they want us to fix it. And for many people with disabilities, they are offended by this in some ways. That that there's something wrong with me that you're always trying to fix, and that somehow that's not taking into account my dignity as a person. Now, this so-called negative history is important to keep in mind because although this is not, by the way, a full picture of the history of persons with disabilities, there is lots of good news throughout the centuries. this is really the history, the sort of popular history, that informs many people today. And why so many people with disabilities are sort of, when they face current prejudice and bias, all of this stuff kind of comes up. The more recent good news stuff has to do with the disability rights movement. I have a few slides on this because it's important to sort of reconceptualize in some ways the way we think about this. The disability rights movement in the United States really started in the 1930s and 40s, and it started with families. It started with families saying, wait a minute, there's something wrong with all this stigma. You know, it just doesn't make sense. Our kids should be in school, they should be in parks, they should be everywhere anyone else is. And these families get together in small grassroots kinds of organizations, eventually coalesced into national groups, and really were the first people to move society's ideas about disability to where we are today. Pearl S. Buck, the novelist, Roy Rogers, the entertainer, were key figures early on, and the Kennedy family, in part because of their access to the White House in the 60s, made a big difference. So this is just one graph showing you that if you look in the 1950s, and before that, there were virtually no federal government programs for persons with disabilities. There's an explosion in the 60s and 70s, so that today there's about $40 billion a year spent in one way or another in healthcare and education for persons with disabilities. And in the 1970s, the disabilities rights movement takes on a much more rights movement kind of feel. Similarities with civil rights and the feminist movements. There are protests, sit-ins, and sort of appeals to conscience, a fight against prejudice. And, you know, so at one point, the secretary of HSS, his office is occupied for a couple of weeks by protesters saying, why aren't you putting into place appropriate accommodations? There are heroes such as Ed Roberts, and I have a picture of him here, who, you know, at first wasn't allowed into Berkeley because how could you have someone with a ventilator in our university? And the chancellor of the university system said, no, you can't come in. And he fought, and his family fought, and it turned out that about a decade later, the governor of California appointed Ed Roberts as chancellor of the system to sort of improve things in the future. So if I were to sum up the disability rights movement, I went the wrong way. There are a number of legal acts and so on, not worth going into the details, although a number of them are being reauthorized as we speak, IDEA and the American with Disabilities Act. One of the ways to make this real, though, is I don't know how many of you know Ed Hockenberry, who was a correspondent for NPR in the 80s or 90s. And it's interesting because he's on radio, so most people didn't know it. In fact, some of his bosses in Washington, D.C. didn't know it. And at one point, one of them found out, and he was supposed to come and cover the Mount St. Helens eruption. And he said, well, you can't do that. You use a wheelchair to get around. And Ed was like, I've had this wheelchair for a long time, and I've been covering all sorts of stories. And it was just one of the examples of the kind of prejudice that people with disabilities talk about fairly often. And one of the things that he wrote about was this idea of, you know, when he first had, I think it was a car crash that led to his inability to use his legs. And they said, well, you know, we can understand how you might be thinking about suicide, such a horrible thing to have happen. And for him, you know, he'd never thought about suicide. You know, his disability was a puzzle to try to solve. It wasn't something to be pitied. And so he says, to hear people suggesting that not existing was better than being without the use of my legs was fairly distressing. Perhaps understated. So if we were to put together in some broad way the keys of the disability rights movement, I would say that it's the basic ideas that all people, regardless of ability or disability, share the same basic rights to be full participants in society. There's not necessarily any honor nor tragedy in disability. There can be, but it's not necessarily there. And it's society's myths, fears, stereotypes that make being disabled most difficult. And lastly, I think one thing we have to say is an expression of anger to some degree at past abuses and ongoing prejudice. So the last thing I want to say before we get into our interactive discussion is, so why bother with this history? How does this fit into clinical ethics? And I hope that I've suggested at least a little bit that these historical trajectories are important for understanding current attitudes and current practice. Also, I think that moral principles and theories can only really be understood in a particular context. This is more of a theoretical debate, which maybe we'll get into in the questions periods. All right, so let's go back to the case. Summarizing it quickly, for those who may have come in late, 3-month-old with trisomy 18 who has a VSD, limb anomalies, microcephaly. What we saw is that there's about a 90% mortality by 1 year of age for most children with trisomy 18. And near certainty, as certain as you can be, of lifelong, profound developmental disability. There's a cleft lip. The parents are requesting surgical repair. They're asking for it now, but in time for the holidays. But again, the child's 3 months, and the mean age of cleft lip repair is 3 months. So then maybe that's not such a big issue. So if we're going to start thinking about is surgical repair appropriate, let's have a discussion about this for a couple of minutes. So here's where my volunteers coming back. So let's start with a test. There are 3 main components of valid consent, right? So valid informed consent. And what would be at least one or more of those valid components? So standing right in the middle, in the back, what would you say is important? If someone's going to agree, in general, to a medical procedure, what would you want to have to be true for them to be able to agree appropriately and validly?
That they're aware of risks and complications.
That they're aware of the procedure itself. So they want to know the risks, they want to know the benefits, and they want to know the alternatives. So they want to be appropriately informed. Right? And we could spend a lot of time about how much information is appropriate. I just actually did this with our second-year medical students on Tuesday. And I had prescribed amoxicillin the day before, and I had all the medical students have all their computers there. And I said, quick, look up the side effects of amoxicillin. And they did. And how many are there? There are about 35 by actual count. So how many of those 35 do you have to share with someone before you can write a prescription for amoxicillin? So knowing how much information and what way to present it is actually really important. But I think you heard from our surgeon colleagues that they have a pretty good sense of this and can be quite good at helping families understand the risks and the benefits and the alternatives. So absolutely. So adequate information, appropriate information, is critical. All right, my other volunteers. Yes, sir, in the red.
Confidence, the ability to make the decision to have surgery.
Excellent. You guys are great. So you use the word competence, which I often use as well, but a lot of people say that's actually a fairly strict legal thing, like only a judge can decide whether someone's competent or not. So we often use the word capacity, but I agree, in general language, they're pretty much interchangeable. So let's talk about that for a minute. How many of you here have the capacity, how many of you are competent to drive a car? A couple of you aren't, but most of you are. In Miami, by the way, this is a crazy question. I don't know if you've ever driven in Miami. How many of you here have the capacity, are able to conduct a symphonic orchestra? No musicians here at all? Usually there are a couple. Well, so part of the point is that none of us is completely competent at everything. And for the most part, very few of us are completely incompetent too, right? Most of us have some capacity in some things and not some in other ways. And most of us feel pretty comfortable about making routine decisions. But for example, if you were trying to decide to buy a house, you might ask for some advice, right? Especially nowadays, trying to figure out how all stuff is working. So there's not an all or nothing when it comes to capacity. And the way that we usually try to operationalize this, and clinicians do this, healthcare professionals do this all the time, is what was often called the U plus A. Now, there are a lot of different ways of doing that. Anyone know what the U plus A is? Understanding and appreciate. So how do we know if someone understands what we're proposing? So I'll go to my back row again. And yes, ma'am, holding your coffee. How do we know if someone understands the risks, benefits, and alternatives?
Anyone ways that they can repeat them back to you?
Absolutely. This is great. It's like you guys are planted to say exactly the right answers. You can stand back there as long as you like. So what she said was, if someone's able to repeat back, and actually all of you know in your clinical practice that there's pretty good evidence nowadays that when we're talking to families just routinely, asking them to tell us what they've heard and what they've understood is a great way of making sure they've actually got the message accurately and improves adherence to clinical regimens. So that's a critical thing to do. And so you don't typically need to have a mental health professional decide whether someone has the capacity to consent to a treatment. You can usually say, well, tell me what you think. What have you heard so far? And if the family is able to explain pretty well, or the person's able to explain pretty well, then you're in good shape. So that's the understanding part. Does anyone know what the appreciate part is? Well, so I'll just tell you. It's easier that way. I may say, yes, I understand that if someone has diabetes and they don't take their insulin, that they can get hyperglycemic and they can go into shock and they can die from that. I understand that. But as I am Superman, this is not an issue for me. The laws of physics don't apply to me. And so that's the second part, is that someone could be quite cogent and very clearly explain to you what's going on, but they may not really appreciate it that it applies to them. Now, this gets really tricky because oftentimes what that means is we as the clinicians think that they're making a bad decision. Right? They don't appreciate how important this is that they need to do this. And valid consent means nothing if we're not allowing people to actually say no. So that's two parts. We've got for valid consent, we have someone has the capacity to make a decision. They're fully informed, and you know where this is going. What's the third thing you might imagine would be important in making sure that consent is valid? I can give you a hint. Suppose the person you were talking to was a prisoner. And what would you want to be assured of as that prisoner was deciding whether to take part in a research study? Okay, so whether they're legally available, and that may be part of it, but also what often happens is whether they're being coerced in some way. You know, if you're willing to take this experimental drug, we'll take 2 years off your sentence. Right? Someone might find that coercive. And so it's not a fully voluntary approach. And I think actually this is going to come up in some ways in this case too. So those would be the three key components of valid consent. Is it voluntary? Is someone fully informed? And do they have the capacity to make the decision? Sort of basic bioethics about deciding stuff. So if this were you, and let's say you were riding your motorcycle without a helmet, which happens often in Florida since we rescinded the helmet law, and you ended up with a major cut on your face, who gets to decide whether you get your laceration repaired or not? What do you think? In the back row and white sweater holding your drink, who gets to decide that? Yes? Right. The person who crashed his motorcycle. And could you imagine this person who's riding his motorcycle without a helmet to say, nah, I don't really want to? You could, right? Here's a guy riding a motorcycle without a helmet. He's clearly not that worried about his personal safety. He might well say. And in fact, you might argue that riding a motorcycle without a helmet is a much worse decision than not fixing a laceration on his face. Right? Maybe he likes the scar. Maybe it makes him look tough. That's what he wants. So if you're assured that he has the capacity, says, yes, I understand if I don't repair this, I'll have a big scar. The chances of infection might be greater, who knows? And he can explain that to you. And he doesn't seem floridly psychotic. He doesn't seem obviously depressed. Right? You would respect that decision. Fair enough. So for adults, this is relatively easy. Adults get to decide for themselves, and you can refuse a blood transfusion. You can refuse life-saving treatment. This comes into play all the time at the end of life for adults. We in pediatrics don't deal with it so much. But when you reach that point, you can decide, no, I've had enough. I don't want to do any more extraordinary medical care. I want to allow natural death. What happens, though, when someone reaches that point in their life and they have to make decisions about end of life and they're no longer able to? Maybe they're in a coma. Maybe they have advanced Alzheimer's. Then how do we know what to do? They come to this side in the black suit with the blonde hair. Yes, ma'am. Glasses.
We would need a kind of surrogate.
Find a surrogate. Excellent. No one's been wrong yet. You guys don't need me. Why did I come all this way? You need a surrogate. And what is that surrogate's job? Here's the tricky question. What is that surrogate's job? You can ask your consultant to the left. What's the job of the surrogate?
To make decisions for the proper medical care.
To make decisions for proper medical care based on what? Based on what that person would have wanted. Right? We call it substituted judgment sometimes, but it's not really that you're substituting your judgment. You're basically speaking for the person who cannot speak. Right? We can all agree that if you imagine what used to be called persistent vegetative state, someone who's in a permanent coma might be another way to think about it, that some people would say, I have a soul, I'm a human being, you never know what the future could bring, you give me every chance. That's my dad, by the way. He never wants to stop. On the other hand, you might have someone who says, I don't want to be a burden to my family. I would hate to be in a state where I couldn't participate in the world in a meaningful way. Please do not continue to keep me alive if there's no chance of recovery. And that's my mom, right? And they're reasonable people, both of them, by and large. And reasonable people can disagree, and we've come to the conclusion that we should respect the wishes of that one person, right? So this is why every single person in this room has filled out a living will, has named a healthcare proxy, has had discussions with that healthcare proxy, and made it absolutely clear what it is that you would want to have done if that should happen to you. And if you haven't already, just think about the Terry Schiavo case, which was among the ugliest, most vicious cases of all. It's the most litigated case of all time. And it was based on that one key problem, that it was a debate over what Terry would have wanted. Of course, the politicians got involved, made it much worse. But that all could have been avoided had she left a clear record. And by the way, all the cases like that, the Anna Quinlan and the others, were all young, relatively healthy people. So it's worth getting that in place. All right, so fair enough. For an adult who's incapacitated, we can use this idea of substituted judgment. What do we do for a baby? What do we do for a baby? So, starting in the back row here in the blue shirt, the young gentleman, what do you do for a baby? You generally rely on parents. And what standard should the parents use? You know, if the healthcare proxy for an adult is that you want to make the decision that that adult would have wanted, what standard should the parents use in trying to decide? You can ask your consultant to the left. Okay, so the best interest model. Dr. Dickman just sort of jumped out of his seat and wanted to say, no. The best interest model is one you hear all the time. And it's very commonly used, and I'm not going to spend a lot of time because I actually don't understand all the permutations of the debate. But there are a few problems with the best interest model. One is, it's not easy to figure out what the single best interest is. And it's always hard when you're trying to compare things like being dead or being alive with significant problems. What's really in the best interest of a person? Is it possible to figure that out? And it gets doubly complicated because we're all parts of family systems. And the younger you are, the more closely connected you are to your family. So, you know, I think the example that Dr. Kim has used, if the family needs to move from one place to another because the dad gets a better job, but the school's not quite as good for the kid, well, is it really in the best interest of that child to move? Well, maybe, because if the family overall is doing better, then indirectly it is better for that child. So figuring out a single best interest is really hard to do. And the model that I find a little bit more helpful is this idea of a reasonable person. What would a reasonable person want? What's the problem with that? Has anyone ever met a reasonable person? So what do you do then? What does a reasonable person want in this circumstance? Well, I think the reason why I find the reasonable person model a little bit more helpful is that you could argue that reasonable people might disagree, right? And there's more than one option that's appropriate. Trying to figure out what the next slide is, if it gives this away or not. I think it probably does. It's all right. Yeah. So this is just a recap, and that way it's sort of there written. So we talked about valid consent. So you need information, capacity. It needs to be voluntary. We talked a little bit about substituted judgment and how a surrogate or a guardian should articulate the wishes of the incapacitated person. When we don't have that situation, someone who has a long-term developmental disability, so no matter what their age, you never know what that person would have wanted, or a newborn baby, you don't know, then the reasonable person standard. So what does that mean? Well, to sort of lay it out, families almost all the time, every day, make hundreds of decisions for their kids, and they're usually pretty uncontroversial. So that makes sense. And also families make decisions for their adult children when they have significant developmental disabilities, although you need to have some legal help to do that. The American Academy of Pediatrics recommends this sort of shared decision-making between the family and the healthcare team. So when people agree, it's usually pretty easy. You know, the healthcare team thinks the best thing to do is, yes, we think repairing the hernia now makes more sense than repairing the hernia later on. These are the risks, the benefits, the alternatives. Everyone agrees whether to go ahead or not. When people disagree, and that's why that third-year medical student is so important, right? You need to have at least one person who says, time out, wait a minute, does this really make sense? because it's relatively easy for healthcare teams and families to kind of get into a collusion to make a decision. And I think that's actually where clinical ethics teams can be really helpful. And in some ways, our job is to establish what the range of actions are that a reasonable person might consider. So who is a reasonable person? You guys are. We are. And we together on a clinical ethics team or more generally sort of say, well, is it reasonable to do a cleft lip repair in a 3-month-old with 90% mortality? Could you imagine that there might be enough benefit to outweigh the risks? And if we as a group, most of us, say, absolutely not, this is just something that we can't imagine, well then I think that helps us make the decision. If we're divided, some of us might say, I might not do that for my child, but I can see how someone else would, and that would be a reasonable thing to do, well then it's sort of permissive. You could also argue, as we have with, say, Down syndrome and repair of a duodenal atresia, that you should do it. You are morally obligated to do it for a child with Down syndrome who, say, doesn't have hypoplastic left heart, which is what Dr. Futin is going to talk about in 3 months. So I think in establishing the range of what's reasonable, it's a socially determined thing. I used the phrase in an earlier slide, there's no higher authority than the assent of the relevant community. Anyone know where that's from, by any chance? It's from Thomas Kuhn in Structure of Scientific Revolution. And he was talking about scientific facts and how we know that a scientific fact is real. I think it applies in ethics in some ways, too. Of course, the philosophers would disagree with me. The other thing that ethics committees can do is the limits of what a community is willing to support. And I do think that we have a role as an ethics committee to sometimes say no to things. But at the end of the day, a well-informed, loving family should make a decision. If the decision the family wants to make is within that range of what a reasonable person would want, then we should probably try to respect the wishes of that family. That's sort of the way a reasonable person would apply to this case. So, it's time to vote again. So, voting as an ethics committee member, okay, and not as, what would I do for my child in this circumstance, but voting as an ethics committee member, I'd like to ask you guys again, is it appropriate to do this surgery? I know there are a lot of issues we haven't talked about, the cosmetic part, the cost, and so on. But at least at this point, how many would say yes, it's appropriate? And how many of you would vote no, it's not? Still a lot of you say no, this is good. So we have 10 minutes left and you can tell me why. So why would you say no, those of you who said no? You might have to use the microphone because it may be more complicated than I can explain. So someone who said no, tell me why.
Pain for the child.
I'm sorry?
Pain for the child with no ability to look back to the medical community and say, you hurt me, and I understand why you did it.
So pain for the child and the inability to say to the medical community, you hurt me, and you were unable to explain why. Do you guys use anesthesia here in Seattle? Good. I just want to make sure. I thought maybe, hey, we use yoga. We don't need anesthesia. It's possible. You're absolutely right. And what we found, if you use the example of intersex disorders and surgery on intersex disorders, for 40 years, we in the medical community said, okay, we need to assign a sex early on, we need to do surgery to fix it, and get everything lined up. And Alice Drager has written incredible stuff about it. She's a historian who actually does empirical research, interviews families, pulls all this stuff together, and talked to a whole bunch of people who had intersex corrective surgery as infants and said, well, what do you think? And by and large, they were very angry. They said, you did all that surgery to me, and I don't think I like what you did. I think you messed me up. I would much rather be who I am, or have been able to decide as an adolescent where I fit on the spectrum of gender. Right? So there's clear evidence that doing cosmetic or any kind of surgery that's not life-saving, especially in the first few years of life, is fraught with difficulty. It's hard to know how it will be judged later on. So I think there's definitely a school of thought that would say it's not appropriate. Next concern about saying this.
Knowing that the team put the hearing there, I'm going to still bring it up. One of the interesting questions in this case was your reasonable person standard. And were the family, in fact, making a reasonable decision? Now, the team chose to choose a single phrase. We want this done in time for our annual Christmas photo or a holiday photo. That raises for me a question about the reasonableness of the decision. Do they really, to use your word, appreciate what they're asking to be done?
Absolutely. And I think this is why, this is where a clinical ethics committee can be so helpful, because without talking to the family, having a real back and forth, it's hard to get a sense of where they are. They may have completely unrealistic expectations of what this means. They may be motivated by things that we all find in this room to be inappropriate. So, for example, you can imagine many scenarios where someone wants to do surgery to their child and it's considered horrible. This is culturally dependent. This is community dependent. How many babies get earrings, like basically in the hospital before they leave in Seattle? In Miami, every child, every girl gets earrings before they leave the hospital, if not at the 2 or 4 month visit. Earrings are a critical part of our community in Miami. So you can easily imagine how different this can be in time and place. And so, you know, that's definitely part of it. So I think that's part of what a clinical ethics committee does. It's also what you and the healthcare team do. So if you get the feeling that, you know, this is a family that's motivated by things that seem they're not really taking into account their child, that's really worrisome. And you might want to keep having that conversation. But we all see that all the time in our clinical encounters, right? I mean, that's sort of part of practicing medicine. So you might have a discussion. You may find out in further conversation that they do see that, you know, overall we want our baby to be part of our lives. We want to be able to go in the community. We want to be able to bring her places. And we know that having a major facial disformity is going to somehow impede her interaction with the world. So yes, we want her to look a little bit more normal, as upsetting as those phrases can be, because we think that will help her interact with the world. And that's probably what the family's thinking when they say, we want it done in time for the card. Hopefully they're not thinking, we have a perfect family. We need everything to be perfect in our lives. And we have this child who, I don't know what happened, but we'll try to fix her as best we can. You know, if you heard that kind of thing, you'd be much more worried about it. There was another...
Thinking outside the box, we think of medicine and surgery, but there are other ways to solve this problem. You can do it with information technology and make it fix it with a computer.
Yeah. So he's pointing out that with Photoshop abilities nowadays, the holiday photo is the least of your problems. Thanks. Dr. Deacon.
Jeff, I think it's important to recognize that the big question you've asked actually, I think in people's minds, wraps up several different questions which can have different answers for an individual person. In other words, the way I answer the question, do I think it's appropriate to do cosmetic surgery on this child, may lead to a different answer than do I think it's appropriate, despite that, to allow parents to make a decision to do this surgery. And there may be yet another answer to the question, whether or not I feel it's appropriate, and whether or not I feel it's appropriate to allow parents to make this decision. Do I think the public ought to pay for it in some way? In other words, should it be the sort of activity that insurance doesn't cover? Should it be the sort of activity that Medicaid doesn't cover?
So in the last 90 seconds, we'll answer all those questions. Just very, very quickly on the resource issue. My feeling is that the American healthcare system is absolutely absurd. Right? There's no way that you could say the $8,000 we would save on this child we would use to do immunization outreach in a community where there are low rates. Right? That's not how our system works. We often have cases in Miami where, you know, the health authority of a relatively small island has a child in liver failure, and they recognize that it's going to cost $1 million over the course of that child's life to do a liver transplant. And that's $1 million they would not be able to spend on Prevnar. I think in that case, you have to make a decision based on resource allocation. We in the United States can find $700 billion when we need to. So it's hard to make an argument that we should not do this for $8,000. I mean, it's unfair. And by the way, I'm a big proponent of making a much more rational healthcare system. But that's a topic for a different day. To try to answer the last couple of questions, so here's sort of my response. Is it appropriate to do cosmetic surgery in a child? I would say yes, within limits. And in this case, for me, cleft lip is probably not simply cosmetic. we could spend another couple hours on that. I'm going to give you a reference in a minute. With profound developmental disabilities, yes. And I hope one of the things that comes out of this is that you fully understand the American with Disabilities Act, which basically says it's discriminatory to say we're not going to do something for someone who has a developmental disability. It may fit into the family's calculations, and if this family decided not to repair the cleft, I think most of us would agree that's also reasonable. And lastly, someone who's not likely to live for a long time. I would say that reasonable people can disagree on what a long time is. If you look at organ procurement and who gets an organ, we don't usually make distinctions between 30 and 40-year-olds. We do between an 80-year-old and a 30-year-old. And I think if I said to you guys, we just had a case recently with a child with Niemann-Pick type C, an infant with acute liver failure. Should we transplant the liver and get 10 more years of relatively normal living? During which time clinical trials may show a drug can stop neurological deterioration. I think some people would say that's reasonable, and 10 years might be worth it. So I think that's hard to figure out. And ultimately, I would say we need to support the family's decision if they're well informed. But coming to that information, in the last slide, just about, is a patient named Kenny, who has trisomy 13, congenital heart disease, and cleft lip, which was repaired. He is now 23 years old. He lives with his family and enjoys basically the same quality of life as when I met him when I was an intern in pediatrics in 1992. He was in my continuity clinic, and he's still in my pediatric practice. And all the predictions about mortality and what was supposed to happen were not true for Kenny. And his family is spectacularly happy that they went ahead and repaired his lip, his cleft. So the last point I want to leave you with is, I won't bother you with Aristotle's theory of the mean, but just point out to be aware of two key things, and this is why I presented the history to you. One is that we in the medical profession prize cognitive ability. When you measure how physicians think about quality of life, how nurses think about quality of life, and compare that to how people with disabilities or families with a child with disability prize quality of life, there's a huge gulf. And we have to be aware of our own biases about not thinking that someone's human and worthwhile. On the other hand, the other major bias in the healthcare community is this technological imperative. We do things because we're able. Someone comes to us with a medical problem, and we are able to fix it because that's what we do. So that's the other sort of bias that we in the medical profession have to be careful of when we're informing families and not coercing them. And with that, I'll stop.
Thanks, everybody, for coming.